to this gathering, and I'd like to introduce Dr. Grunwald. He's going to talk a little bit here. And also we'd like to welcome Dr. Parda and Don McNary from West Penn Alleghney Health Systems. And Dr. Grunwald, go right ahead.
Good morning to all of you, and let me add my welcome to that Mike is providing.
Hey Doc, just for our guests' sake, would you kind of introduce yourself?
I'm Joe Grunwald. I'm president of the Capital Campaign. It's raising money for the Linear Accelerator. I was an ex-Clarion Gold Eagle. I guess once you're an Eagle, you're always an Eagle, so I still have that in my blood. I do a number of pro bono consultings around it, and I'm on the board, chairman of the Affiliations Committee, on the board of directors here, chairman of the Governance Policy Committee. So that's what I do. Okay? I'm retired, I hunt and fish and play golf like crazy.
Golf not so good.
Not so good. Not so good. Some of you see me play. We're a very different group of folks that are gathered today. And I guess you might ask the question, what is the purpose of our getting together today? And it has several levels of purpose. One is that we provide for you an opportunity to see what is real about this cancer program. I know that you know that we're out raising money. John and myself, Lisa Goff, all kinds of folks are out raising money to develop this linear accelerator. But to know how that fits into the context of what a board is trying to accomplish and what your local management is trying to lead and what all of you are trying to deliver is really important, and that's what today is about. Over the next couple of weeks, those of you who are internal to the hospital will have opportunities to have town hall meetings where you can come and ask questions about some of the things that I'm going to mention to you right now, and some of the things about this program set in the context of a long-range plan for the success of our hospital. So whether we come as donors, or whether we're here as management, or whether we're here as a department head, or whether we're here as volunteers who work on various committees and councils, one thing we do have in common is the desire to advance this hospital. This hospital is critically important to the future of our community, to the future of our patients, and to all of us who have direct personal relationships, whether it's an employee or a volunteer or maybe a patient in this facility. So I want to talk to you just a little bit about what all of this means, how it's set in our context, and what it clearly doesn't mean. You might ask, how does a board of directors of a hospital go about identifying long-term objectives? And how does this particular project fit into those long-term objectives? Well, I can assure you that being here as a member of the board, and there are several others who will echo this if you ask them, our objective is to maintain this hospital as a strong, independent community hospital with a wide palette of high-quality services. That is the board's objective. And we're going to do whatever it takes to get that done. Now, how does this project fit into that? Well, the ways you deliver on that kind of objective is to provide high-quality care, advance the technology and medical development of your hospital, and to create net revenue with opportunities and partners. That's how you get that done. This particular project fits all those three perfectly well. It will provide high-quality care in addition to what we already do down in that cancer center. That is simply outstanding. You can see it on the faces of the patients. You can see it on the patients of the medical staff and the nurses and others who work down there. We want to develop the next part of that so that we can deliver that high-quality care. It does advance a technology agenda because not only is the linear accelerator coming on, there are 3 other imaging devices that we need to be at the nth degree of our diagnostic capability with those imaging devices. So this thing is important. It advances our medical capability because on site we can provide services we don't now. And lastly, it provides net income. It's wonderful to provide high quality care and advance the agenda, but if you can't do it in such a way as to be sustainable, then you can't do the project. I can tell you, being a businessman, that this does generate net revenue, not only from the direct stream of revenues provided by the nuclear radiation, but also in terms of the ancillary services that will be provided to that center in-house. And here we're talking about our lab stuff and our imaging stuff and other services that need our people to support that cancer center. That's really important. Now, you did hear me use the word partnership. When you bring up the word partnership, everybody, it's kind of like people scratching their fingernails on a blackboard. Because partnership often means ownership or control or being sold or being merged or any of those kinds of things. I can assure you that this is not, our partnership is not anything to do with ownership, control, or where we're taking this hospital in the future. Partnerships have to do with finding people that have strengths that complement your own and to engage in a relationship that's best for both organizations. And clearly, this is one of those where we're going to form a relationship with West Penn that's good for all of us, that provides not only the technical capability, but all the other services that surround this, because we're going to be part of a network that is not controlled but participating in a delivery of service in Western Pennsylvania. And so all the advantages of information technology and all the personnel and all the doctors and all the things that a network can afford that we might not be able to afford will be brought to us by West Penn. And we will provide for West Penn a northern partner along the lines of their protocols and dictates that provides high-quality service that's compatible with the advancement of their own medical agenda. This whole thing about partnerships and allegiances and affiliations always kind of gets back to the big bear in the room. You know, we hear you're going to get sold. We hear you're going to join a partnership. We hear you're going to get an agreement. I can tell you that I've been on the board for 10 years. We have never had a stronger board more committed to independence of this hospital. And that I can tell you, as my role as chairperson of the affiliation committees, there are no deals on the table. And as chairperson of the governance committee, which would have to make a recommendation to the board on any contract, there are no deals on the table anywhere in our organization. We are not going to talk to anybody about a merger or an acquisition. So I guess I want to get that said, because we're going to be partnering up with a pretty big, pretty important player here. And I don't want you to start out thinking that there's anything other than the true medical partnership we're trying to develop that advances both of our organizations. This is huge. John came to me, I don't know, about a year or so ago, and you know, I knew that the campaign was going to get going. I'm on the board. You know, I voted for the linear accelerator because I thought it was a good idea, and so I figured, you know, the ask was coming. But it wasn't the ask that I thought about. He didn't ask for cash. Oh, we got around to that, believe me. He got around to the cash part. What he asked me to do was to co-chair the campaign. And I thought to myself, oh, smokes, man, I'm retired. I hunt and fish and play golf like crazy. Like, I need a capital campaign. But as I thought about it, I recognized that this is the single most important thing that can be done, not just for this hospital, but for this county. This particular project brings a strength not only to the hospital, but to all the patients that will be served and all the people who will be resident in our community for years and years to come. With that looking you right in the face, how can you walk away from that? And you can't. And you can't walk away from our ability and our desire to build the strongest possible independent community hospital with high-quality services that advances care right close to home. And with that, I'll introduce Byron, who's got some things to say, and we'll introduce our speakers for the day. Welcome.
I'll just thank Dr. Grunwald and Lisa Goff for their efforts in raising a lot of money, and to date it's about 1.5. 1.5. So we're on our way to our goal of 2.5, and so they have plans to, you know, we're going to start the internal campaign with our employees and push it out to the community a little bit, so they're going like crazy. So I'd like to formally recognize our guests, Dr. Parda, Dan McNary, who is Vice President of the Cancer Neuro Ortho Service Lines, and then also Richard Billy, who is the Director of the Oncology Network. Dr. Parda's assistant sent me a bio, and it's quite lengthy, and it's single-spaced in real small print, so I tried to glean some stuff out of it and do it by memory, but my memory's shot, so I'll read some. But before that, I wanted to say that I was impressed. I attended a CEO conference down in Nemacolin, at which Dr. Parda was one of the presenters. And his presentation was so dynamic, and I was so impressed that I thought that it would be important for us to have him come up and to do his background and tell us what they've done in terms of West Penn and the building of that service line and that process done at West Penn. I'll just read a few of these sentences. Dr. Parda is System Chair of the Department of Radiology Oncology at Alleghney General and West Penn Alleghney System. He has developed 8 primary programs in radiation oncology to integrate a network of 11 radiation oncology clinics in western Pennsylvania and eastern Ohio with advanced technology and data collection processes. AGH and throughout West Penn Radiation Oncology Network is recognized regionally, nationally, and internationally as a leading academic radiation oncology program. As chair of the Cancer Institute for West Penn, Dr. Parda is integrating 6 primary departments and divisions and 11 additional cancer services throughout more than 25 inpatient and outpatient locations in the Pittsburgh region. He has served as Radiation Oncology Residency Program Director at Alleghney General Hospital from 2002 to 2009 and maintains involvement with educational programs as Associate Residency Program Director. He serves on the American Society of Radiation Oncology Best Practices Committee and 11 other radiation oncology experts from the USA and is physician representative from the U.S. on an international oncology experts group that is mapping the future of radiation oncology technology and advanced oncology workflow over the next several years, having been selected among 10 leading oncology experts from the United States, Europe, and Asia. So, as Dr. Grunwald said, we are partnering with a group of facilities and individuals who bring to us the latest and the best services in oncology, radiation oncology. So with that, Dr. Parda? Did we get you all set up here?
I think so.
Okay.
Thanks a lot, Byron. I just wanted to say that I don't do a lot of hunting and fishing, but I play golf pretty poorly. In fact, it's been about 30 years since I graduated from college. I went to Vanderbilt University. I grew up in Pensacola, Florida, a small town in North Florida. And when I get together with my college buddies, they say to me, "I can't believe you're this bad at golf. You actually used to be a pretty good athlete. What happened to you?" And I'm like, "Well, I guess medicine. I don't know." But I really appreciate the comments that were made because we have felt strongly. For 12 years, Don McNary, Rich Billy, and I have been building this radiation oncology program. And our approach has been that we want to respect and support communities. We think that a community hospital like this is a vital asset to the community, and we want to keep that asset in the community. So when you talk about partnerships, that's exactly the way we think about it. We don't think about it in terms of control and ownership. We think about it as a two-way street between us and the community to provide service and value. And when we think about the 3 main things that we're doing for our cancer services, first thing is to keep cancer care in the community. That's job number 1. Number 2 is to integrate quaternary and community cancer care. You have to have that two-way street to really optimize patient care. And then the third thing is to innovate so we can help evolve the delivery and financing of healthcare to a better state. So that's really what we've done. Don and Rich started out as clinicians in the field of radiation oncology as therapists, dosimetrists, treating patients. They both got a lot of management training. Don's got an MBA. Richard has extra management training. And all of our management activities and financial activities are surrounding clinical and operational support and supporting patient care and healthcare professionals. So that's our ethic, and that's really why I think a partnership like that works. The other thing is that when we're talking about those three main things of keeping care in the community and integrating quaternary and community environments and innovating the financing and delivery of healthcare, that's completely aligned with Highmark and the integrated delivery system that they're building. They want those exact same things. They want to keep care in the community. They want to have these two-way streets between quaternary and community environments. And clearly, as they build a delivery arm to their financing arm, we're going to be doing a lot of work to try to balance financing and delivery in healthcare and get the volume side of things well, so working right. So you can see that that's our mission and our vision. The vision is always to take care of each patient where they have the best possible outcome in terms of cancer control, toxicity, efficacy, quality of life. And you can see that we really do, this is what we want to do. We want the great majority of cancer care to be delivered in patients' communities. Why? Because the patient has all the answers for us. It's best for their overall well-being and their family's well-being. Now, clearly they need to have access to developing cancer care that we would be doing at a quaternary tertiary environment like Alleghney General Hospital and West Penn Hospital, and we want to make that easy for patients. So in order to do this work, we really do have to overcome some myths. Myth number one is that patient outcomes for cancer and other diseases are better at university or quaternary tertiary teaching hospitals and centers than community hospital centers. That's not true. It is absolutely not true. It's a given that it's more convenient for people to be treated close to home in their communities. It's also a given that it's more cost effective to be treated close to home, whether it's for the cost of the treatments or the cost of the patient and the family. The issue that we really have to wrestle with and come to know and understand from the data is that care and outcomes can be better in the community also. I think it helps when you have these two-way streets between quaternary and community environments, though, that work well. Myth number two, doctors at university or quaternary tertiary centers are smarter and better than doctors at community centers. That's a crazy notion, and I think you know, a lot of people that work at big academic centers, you know, living on an ivory tower, and I'm an internist first, a radiation oncologist second. I trained in internal medicine at the Cleveland Clinic and radiation oncology at Georgetown University and the National Cancer Institute, and you know, these places train people that come work in these communities and all over the place. We were on vacation a few years ago, and my wife got really ill near my hometown of Pensacola, and had to go to a hospital called Gulf Breeze Hospital. She had respiratory failure. She's got a severe autoimmune lung condition, and she had to be put on a ventilator. And you know, she got through it. It was a community-acquired pneumonia, fortunately. And these doctors were great. They took care of her as well as anybody would have at the Cleveland Clinic. That's for sure. And we need to get that message out there that that's exactly what happens in communities, and that's Highmark's intent as well. But you know, there are different kinds of jobs. I mean, my job at Alleghney General is different than my partner's jobs out in the community. Mine is more expert specialty, where we focus a little bit more on specific disease sites, in my case like breast and colorectal and head and neck. Whereas out in the community, you focus on expert general care. So my partner out at Forbes, for example, Steve Analik, you know, he's better at taking care of a community clinic than I am. That's his skill set. My job is to get some of the advancing approaches in a specific disease site out to him in a timely manner. The other one is that Hillman Cancer Center has the best outcomes for cancer patients in the Pittsburgh region. That's not true. Now, it's been hyped quite a bit. The corporate hype, you know, spending $20 or $30 million a year on all that advertising, you know, people believe what they hear. But this is the myth, these rankings. And you can see that cancer is their lowest ranking. They actually don't do a very good job in cancer. But the data, what U.S. News and World Report will tell you is that 40% of that ranking is based on a reputational score. And since so many people have been annoyed about how this has been gamed and gamed at the corporate level, there's been a lot of scientific analysis of this, and it's really more like 80 to 90% determine these rankings. So here's the facts. What matters is you're only as good as the last patient you took care of. So when it comes to the objective data in these U.S. News and World Report rankings, the objective data is patient survival and patient safety. And in cancer, that's the highest possible level that you can achieve at Alleghney General Hospital, much better than expected and superior. And you can see that UPMC was one rung down in terms of their patient survival and patient safety. And the other thing is that in all of those other disease sites, Alleghney General generally performs better than UPMC. Now, we have obviously had a lot of challenges at the corporate management level and the finance level for many years at AGH, and we're excited about moving beyond that as we work with Highmark. But that's all you tend to hear about. But it's really a culture of clinical excellence and putting the patient first that has kept that going at AGH. That's why I've stayed and worked at AGH, because I can work with my colleagues in a very collaborative and collegial way to take care of patients at the highest level. And Alleghney General was the only hospital of nearly 900 hospitals that had the highest possible scores in survival, keeping patients safe, patient volume, and nurse staffing. And that includes all the top the hospitals that were ranked in the top 50. So here's what the ranking looks like. University of Texas MD Anderson has got the #1 ranking for cancer. You've got Sloan Kettering, Hopkins, Mayo, Harvard, University of Washington, Mass General, UCSF, and you can see the reputation with specialists, very strong. That's the primary driver for that, and it's not really based on a whole lot of data. And then you go down through #10, you can see Roswell Park up there in Buffalo, 27, UPMC 29, Fox Chase 38, McGee 45, AGH not ranked because of lack of reputation, but it really does show that a lot of that corporate activity is a driver. I mean, UPMC has full-time people that are managing these rankings, and you can see that the AGH score is much better than expected, superior, highest in these are better than McGee's, yet they got a ranking based on how that's worked. These are other, Temple and Hahnemann, we have affiliations with those medical schools. They generally have pretty good objective data. You can see as far as these other UPMC hospitals, when you look at UPMC St. Margaret's, and their survival's worse than expected and moderate in terms of keeping patients safe, that's, not nearly as good as what we've been able to keep together at AGH and West Penn. So Highmark did this survey where over 1,800 people responded, and they asked which organization provides the best cancer care. And Hillman came up 12% of the time, then you got Hopkins, Cleveland Clinic, Sloan Kettering, Mayo Clinic, AGH, West Penn, Alleghney, MD Anderson, and no strong opinion. I think this has a lot of meaning because what it shows is that it's confusing for patients and healthcare professionals what all these rankings mean. I'm a healthcare professional, been doing oncology for 25 years now, and of course you want to be the best. Of course you want to take care of the patient the best. And what do these rankings mean? And I think that for the most part, people are relying on us. I mean, we're all doctors went to 4 years of college, 4 years of medical school, and when you do oncology training, it's 5 to 7 years of additional training. So you're ready to take care of patients, just like those doctors at Gulf Breeze Hospital were ready to take care of my wife. So I think people know that, and a lot of this noise can be confusing, though. And I think a big part of our job with Highmark is to really make it less confusing. Just get these basic facts, help patients with these basic facts. So integration and innovation have been the most important components in terms of developing our radiation oncology program over the last 12 years, and it's the most important aspect of our work as we integrate all of oncology. So when we're talking about all of oncology, that's surgical oncology, medical oncology, radiation oncology, thoracic oncology, neuro-oncology, GYN oncology, and I'll show you in just a couple of slides how we operationalized it in radiation, and then how we are extending it to all of oncology, and also how that platform allows us to accelerate treatment advances in a quaternary environment and accelerate that information transfer to the community. So integration, I mean, it's not an accident that John Paul and Highmark are calling their delivery arm the integrated delivery system, because integration is the key to success, but it's hard to achieve. So we've worked at integrating patient care, education, research and development, quaternary, tertiary and community care, clinical, operational, financial and IT functions, and competencies and values. I mean, when we're training medical students and radiation oncology residents and ourselves, we explicitly say it's a given. You got to know the information, but you have to have a value of really caring for patients and your colleagues and putting the patient first. So the Institute of Medicine has been trying to give these academic medical centers some guidance to get off their ivory tower and say, listen, your job is to really integrate all of these activities and improve the health of patients and populations. That's what you guys do here in your community every day, and we need to be engaged in that and help with that, and we've embraced that with our work. So, and you tend to be a little bit further along in radiation oncology because we can't treat the patient without a computer. It's all computerized in radiation now. We've got a lot of equipment, so these are all of the sites that we have with all of the different equipment. We treat about 3,000 patients per year. More than 50,000 radiation treatments are delivered, 14 linear accelerators, 2 high-dose rate brachytherapy units, simulators, and a bunch of treatment planning computers. So it's critical for us to bring all that together in a highly integrated manner in order to keep patients safe and also healthcare professionals safe. It's made the news that some radiation misadministrations have killed patients, and the technology is getting more and more complex, and you have to contain that complexity for not only safety for patients but healthcare professionals. Some of the healthcare professionals up in New York at St. Vincent's Hospital, where the patient was killed with intensity modulated radiation therapy, they're never going to be able to practice medicine again. And this is really why it's happening. When I first started in the late 80s to do radiation, we had about 10 machine setting parameters. Now there's over 100,000 as we're doing these treatments. There's no way that a single physician or a single technical person can keep all of that together, so process becomes key. Also, when you're targeting tumors, you're adding one type of methodology after another according to the complexity of the problem. So liver cancer, I'll show a couple of slides showing how this is the most complex targeting problem, so we have to add 1, 2, 3, 4, 5, 6, 7, 8 things to be highly accurate in terms of targeting that tumor. So this is why a research institute that focuses on healthcare technology back in 2011 said that radiation overdose and other dose errors during radiation therapy was the top technology hazard. And you can see 4 out of the top 5 are related to radiation oncology in terms of data loss, system incompatibilities, and other health IT complications. Don and Rich and our group have gone through over the last year a lot of due diligence to really look at what we need to do to upgrade our platform and keep it interconnected. There's a lot that has to be put together for that. And you read a lot about excessive doses of CT scans and these alarm hazards. All four of those are operational in a radiation oncology environment every day. So Atul Gawande is a really smart surgeon who writes a lot about healthcare as it is today, and this is his quote: "Medicine's complexity has exceeded our individual capabilities as doctors," and that's the humbling reality that we work in radiation oncology, and more it's happening in all medical fields. So that's how we've contained the complexity in radiation oncology. So 3 years ago they asked Don and me to do this for all of oncology for West Penn Alleghney Health System, and I guess we were masochistic enough to say, okay, we'll do it. But you can see the patient's in the center of everything we do, and then those are those 6 departments and divisions. And then there's those 18 ancillary services that surround the patient, that need to get to the patient. 4 different location types of practices, and then all of the corporate activities. And a lot of the way we're structuring our work is to try to break down all those barriers and the silos of all these activities so we can get it to the patient in a much more seamless manner. And so to do that, you just have to keep your focus on the patient. The patient has all the answers, follow the patient. So navigator groups, we've broken up 12 disease sites so that we can help these patients more efficiently navigate all of that activity. These are the 12 disease sites that we've set up. And you can see that we have surgical oncologists, medical oncologists, radiation oncologists, pathologists, imaging folks, IT experts, research experts, nurse navigation, and other key departments that we're going across all those 6 different departments and divisions to optimize our activities in these disease sites. And we're doing this, it's about 25 sites now, many med-onc, rad-onc, and surg-onc clinics. So, you know, you get to the patient level, you get to the disease site level, then you get to the location, and you're just trying to keep that integration as tight as possible. So on the innovation side, Clayton Christensen's that famous Harvard business professor who pioneered the thoughts of sustaining and disruptive technologies when he wrote The Innovator's Dilemma, Innovator's Solution, and Innovator's Prescription. And that has been a very helpful concept for us in the radiation oncology environment, so that in our community hospitals we need to have a bulletproof sustaining technology platform, and that's what's represented at the top. At the quaternary and tertiary environments, we need to have disruptive technologies that we're working on, and over several years we optimize, and as it's ready for prime time, then we send it out to the community. And we're thinking the same way for all of oncology with regard to sustaining treatments and disruptive treatments. So that could be chemo treatments, surgical treatments, radiation treatments, etc. And these are the 4 primary nodal points of work in radiation: the oncology information system, the simulation, treatment planning, treatment delivery. And in order to optimize the patient's outcome, you have to optimally conform the radiation physically, but know about biologically where the cancer is located, and then gather more information in terms of dose response characteristics of the tumor and normal tissues to optimize things. This shows all the different types of technologies that we're working on primarily at AGH to get ready to send out to the community. And we were one of the top global sites for collaborating with Siemens Medical Systems. They're now the top company for selling imaging devices. That's their particular strength. They also made linear accelerators. Within the last year, they decided to get out of the linear accelerator business, but we had a very fruitful collaboration with them for 10 years on both the imaging and the rad-onc delivery side. This just shows a lot of the technology that we helped them develop and some of the papers that we wrote there. And we're setting up that exact same platform as we move forward, and we're assessing both Alleghney and Variant. So this Integration and Innovation Foundation accelerates treatment advances. It improves the community quaternary tertiary coordination and improves multidisciplinary care, breaks down these silos, it shortens disruptive technology and treatment cycles. One of the things, I mean, you might have heard this fact that it takes about 17 years to get a new treatment as a standard of care in the community. Well, you know, that's way too long. We need to get it to a few years, and as we're dealing with all that technology, generally it takes us about 5 years, 3 to 5 years to really master it at the quaternary environment so that it's safe enough to send to the community environment. So the quaternary environment just has a little more infrastructure, some additional people to work on that. When you send it out to the community, there's less infrastructure, so it needs to be streamlined and optimized. Improving the flow of knowledge and treatments to the community, I think that's the biggest issue. With this information explosion, we got to help each other deal with all of this knowledge out there, and that not only improves the patient experience and outcome, but healthcare professionals' experience and outcome. Pittsburgh has a very strong foundation for integration and innovation. The picture on the left is what a radical mastectomy looks like. The picture on the right is what breast conservation therapy with limited surgery and radiation and folding in hormonal therapy, biologic therapy, and chemotherapy looks like. So 50 to 70 years ago, the cure rates for breast cancer were 20 to 30% with that cosmetically and functionally morbid surgery. Now the cure rates are about 90% or greater, and obviously not only do you have better cancer control, but you have less toxicity and improved quality of life when you're able to treat patients like that. Bernie Fisher was the tough Pittsburgh breast surgeon who basically said, hey, we need to do less breast surgery on these people, not more, and he was tough enough to get a bunch of doctors together and collect enough data to knock Halstead off of his surgical throne. We generally think it's a little bit of a bad sign if you name a procedure after yourself. You tend to be a little bit of a megalomaniac there. So the Halstead radical mastectomy is, what he was promoting essentially from Hopkins for many years and holding the whole field hostage by that, saying that I'm the only one that can do this. Well, what it took was Bernie Fisher and a bunch of other breast surgeons saying, you know what, that's not what we're seeing with our patients. That's not the data that we're seeing. And now the study group that Bernie Fisher started is called the National Surgical Adjuvant Breast and Bowel Project. It's based at Alleghney General Hospital. Its operations center, it covers 1,000 sites throughout the United States and other countries, and over 6,000 healthcare professionals are involved to continue to evolve and advance breast cancer care. So in 2013, cancer cure rates are rising, cancer death rates are decreasing. That's because of incremental advances in surgery, chemo, biologic therapy, radiation, computer and imaging technology, and advancing knowledge, expertise, and multidisciplinary coordination of care. It's not one thing, it's all of those things, which again speaks to the reason why you have to integrate. There is an increasing importance of second, third, and fourth line chemotherapy, biologic therapy, surgery, and radiation, and for the most part, we want to keep delivering that in the community and increasing the importance of these specialty radiation procedures. So in order to do this work and optimize the outcome for the patient, you have to have surgeons, rad-oncs, and med-oncs really working together saying, hey, here's what my modality is best for. Put the patient first, not your modality, and say, how do we mix and match this for each individual patient? And for each patient, if you do that, you get as high as possible on the tumor control probability curve and as low as possible on the normal tissue complication probability curve. And a lot of these advancing technologies in radiation have been helping with both of those. So just a quick example of how this platform helps us with moving our liver cancer program forward. This has been one of the toughest types of diseases for us to deal with and control. These are the groups of people that have been coming together to do this work. It's led by Nak Tai, a liver transplant surgeon, and oncologic surgeon, and Alex Kirichenko from our radiation oncology department, as well as Moses Raj and Dulab Manga from medical oncology, along with other doctors from interventional radiology, gastroenterology, etc. And typically surgery has been the gold standard in terms of curative treatment of liver cancer. A lot of surgeons use radiofrequency ablation, and stereotactic body radiation therapy has been something that we've been studying more over the last many years. This is what it looks like. It's pinpoint, very focal, localized radiation. The issue in terms of the complexity with the liver is it's right by the diaphragm, so it's moving up and down, and it can move up to a couple of centimeters. And when you're delivering these high doses of radiation to small areas, you have to be able to follow that and track that to not miss the tumor. So this is a 51-year-old patient who had colon cancer and 7 liver metastases. And the patient underwent a bowel resection, the large bowel resection, a colectomy. He got chemotherapy with 6 cycles, and he had a good response, but he had persistent liver metastases. So we took him to surgery and resected the ones that could be resected. And you see the one that is unresectable there. Since this is hard to see as we're doing the targeting on a daily basis, we put a gold clip fiducial so you can track that. This is what the treatment planning looks like, and you also have some functional imaging scans so you can identify normal liver volume so you can avoid that as much as possible. A lot of these patients with liver cancers have cancer in a certain part of the liver, but then some of the liver doesn't have normal functioning cells, and it's better to have the radiation delivered to the poorly functioning liver cells rather than the better functioning liver cells. So this is what happened. The patient's CEA level, that stands for carcinoembryonic antigen. It's a test from the bloodstream that is elevated in colon cancer. It was very high at diagnosis. You can see it went down some at surgery, but not completely because there's residual cancer there. Well, it went down some with chemotherapy. This is after the chemotherapy. This is when we did the surgery and the radiation. And 4 years later, he's without evidence for cancer. And this patient, if we had not done that surgery and the stereotactic radiosurgery on him, would clearly be dead. But, you know, this is the type of thing that we're getting sorted out. Here's another example. We're doing this with hepatocellular carcinoma, and this is just the concepts that we're keeping in mind as we move this treatment forward. You know, we started doing this in 2007. We're doing about 40 cases per year now as of 2011, more in 2012, and this is what our data looks like. 68 cases at AGH there on the bottom, and compares with these U.S. multi-center trials and European trials. And that's our local control in the area that was treated, which matches up favorably with these other sites. So, you know, this is the kind of work that needs to be done in the quaternary environment, but our goal is to get this out into the community as soon as possible so patients don't have to travel for this. But when you think about their care, you know, in the current setting, I mean, eventually we're going to be doing this liver SBRT at all of the community clinics, but as it stands now, you can do the chemotherapy and all of the follow-up care there. The only 2 things you really have to do in the quaternary environment would be the surgery and the SBRT at this point. So as we compare this stereotactic body radiation therapy to radiofrequency ablation, it really is helpful to have your surgeons just look at the data in an objective way. I mean, this takes a lot for a liver surgeon to say, geez, I'm going to do less liver surgery. You know, the people that are evaluating me are going to say, geez, you're not as productive, you're not generating as much revenue and all of that, which is why we really want to roll up all of these revenues and costs along across departments and not silo it off. And so our determination has been that this type of radiation procedure is superior to what is more commonly being done as far as radiofrequency ablation, and the question is, can SBRT reduce the need for liver surgery? And we're using this as a bridge to liver transplant also without compromising patient care, and this is what our group thinks. This is more and more what is being thought out there in terms of the national and international community. So we have these accelerating disease-specific treatment advances going on in all of these disease sites. This is just a listing of some things going on in breast cancer, prostate cancer, lung cancer, rectal cancer, brain and spine tumors, head and neck, liver, stem cells. So similar to that example I was just showing you about with liver. So I'll end just showing, giving a little perspective in terms of the scope of the cancer problem. 1,600,000 new cancer cases in the U.S. in 2011, 600,000 deaths from cancer, 600,000 from cardiac disease. But now cancer is the leading cause of death in people under 85. So over 85, it's still cardiac disease. The lifetime risk for developing cancer, 44% for an American man, 37% for an American woman, and that's a life-threatening cancer, not a non-invasive or a cancer or a skin, relatively benign skin cancer type. And cancer kills 1 American every 56 seconds, and despite treatment advances, metastatic cancer generally remains a death sentence. We're definitely making a lot of progress with metastatic colorectal cancer, and we're applying a lot of that to these other disease sites. We have patients now that are 15 years out from having metastatic colorectal cancer and free of disease. So by 2020, the data shows we're going to have a 50% increase in the number of cancer patients and cancer survivors, a shortage of about 4,000 medical oncologists and 1,000 radiation oncologists. We know that we need to train more people, and we're starting to increase the numbers in these training programs. And we know that we need to improve quality patient experience and cost in cancer care. We need these comprehensive and integrated quaternary, tertiary, and community programs to care for patients and to really optimize the sustaining technology and treatments. That's what the Institute of Medicine was really trying to tell academic medical centers. And then integration and innovation are key drivers of improved patient outcomes, viability of programs, and sustainability really of a healthcare professional's practice these days. So in order to do this work, we know that we have to help evolve healthcare from this hierarchical, autonomous, competitive, individualistic, expert-centered structure to a more collaborative, team-based, service-based, patient-centered structure. That's how our radiation oncology program works. We're trying to make sure that all of oncology works that way. This is my 27-year-old resident here on the right. That's how he views me. I guess I'm an old guy now since I'm 51 and almost twice as old as him. But you really can bring together these different age groups and different cultures, and we've really enjoyed our collaborative work, and it really does help to be collaborative and collegial. You really can't take care of patients well if you don't take care of each other well. That's the way we've thought about it. We've been working with Ann Rhodes, who wrote this book about creating an enviable culture that outperforms the competition. She pioneered a lot of the people processes at Southwest Airlines, JetBlue, DoubleTree, and she's been working in healthcare. We've been working with her for the last about 3 years to really help with this culture that really just focuses on the patient, keeps the patient first at all times. And we really do think that does help us outperform the competition. We think the facts show that. So we're embracing a culture of patient-centered care with these navigator groups, disease-specific programs, and we want to optimize clinical outcomes, efficiency of care, patient satisfaction, and cost. And we think that we're, by working like this, we're able to help evolve from these patient-centered, volume-driven transactions to more patient-centered, value-driven care. And that really is a big part of our work with Highmark. How do you balance this volume-value equation? And so our focus, the values-based management and culture, collaboration and collegiality, integration, innovation, and we work every day to optimize staff, equipment, IT, programs, and training. And That's the kind of collaborative partnership type work that needs to occur, not aggressive takeovers and owner and acquisition types of methodologies. So we have not. We've been competing toe-to-toe with UPMC for many years, and we don't want to function like that, and neither does Highmark. So thank you very much.
Take a couple questions? Oh, you
Go ahead.
Fine. Anybody have any questions? You want to ask the doctor, the two gentlemen here? Good.
What percentage of the people that go to a community center like Clarion Hospital have to go on for further treatment at some of the other centers?
I'd say it's less than 5%. Yeah. Initially, as you're getting everything organized, it may be 5 to 10%, but the whole point is to, in those 12 disease sites, that example of liver cancer would be one. There's the volume of those types of cases is relatively low, but when it comes to the four most common malignancies, breast cancer, prostate cancer, lung cancer, and rectal cancer, that's at the sustaining treatment level, and all of that needs to be done in the community. I'd say those four main disease sites would make up about 80% of your volume.
So, fine, go ahead.
I just think that this is an example of why we want to partner with somebody so that we, as the hospital, don't get behind the curve. I think a partnership allows us to stay ahead of the curve because they are innovative and they're creative in what they're trying to do with their patients, and if they can push that down to our level, the community level, our patients stay here, get better treatment, the latest and greatest types of treatment that are coming out to small rural hospitals. Without that, we could go along, but we wouldn't be as in the forefront or as creative. So as we go forward, I think this is going to be a great partnership, and I hope you can see from, as I did when Dr. Parda was the presentation down in Nemacolin, that he is pretty on top of cancer and radiation treatment that anybody else I have ever talked to. I've talked to a couple of my colleagues who have West Penn or Alleghney General and Dr. Parda as the chief, talking about how their patients work and how their departments work, both the radiation oncology and the medical oncology, and all of them just rave about the relationship they have with AGH and West Penn. So thank you guys for coming. Appreciate it. If there aren't any other questions, we can all go to lunch. Oh, I'm sorry.
If you can briefly describe how this partnership works. In other words, if the equipment is all here and you have a patient that is diagnosed with a particular type of cancer, how do you direct treatment? Or is someone physically here, comes here, or how does it work?
Yeah, somebody physically needs to be here. The radiation oncologist needs to be physically here, the radiation therapist, the dosimetrist, the nurses, the administrative staff. It's key to be in the community and a member of the community. So the whole structuring would be to have a Clarion Radiation Oncology Center to be Clarion. What the main stuff that we do from the main center is to help with the staffing, the equipment, the training, and the program. So, that doctor, our policy is 4 weeks of vacation, 2 weeks of meetings, so we would provide coverage for that person, also coverage for the dosimetrist therapist. Typically the hospital controls the nursing employment and also the therapy employment, but we'll work that out however you guys want to do it. But the people taking care of the patients here on a day-to-day basis need to be part of the community, and we'd want them to be here and preferably live here or live close by. We do, with the technology, we do have the ability to be electronically connected to the main center, so real time you can help optimize treatment plans and do peer review electronically. So we do focus on that. We have never thought that you can do this from afar. It's got to be in the community.
What's the timeline look like for bringing your staff here and getting it up and running?
Well, like I said during the talk, it's been almost a year as we do all the due diligence for the equipment. And I mean, we're upgrading our entire radiation oncology platform, and we want Clarion to benefit from that and to be connected to that. It also helps in terms of patient safety and flow of information if we have technology standards. So that's coming to a conclusion. Don and Rich are bringing that to a conclusion over the next couple of months. It usually takes about 6 months to get a radiation oncologist in place, and as far as therapy and dosimetry staff, since Don and Rich have such great relationships with so many people, and they were therapists and dosimetrists themselves, they can usually get people on board in less than 6 months. But it's and we've done a lot of the due diligence in terms of planning out what we think the volumes would be like, and how you would surround that with the technology and the staff, and it really is a two-way street between our environment, your environment, and in terms of optimizing not only the clinical activity but the operational and financial activity too. This radiation equipment is very expensive, so when we're integrating all of this, the whole goal is to minimize some of that cost as well. So we've already done a lot of work with Byron over the last 6 months, 9 months, I guess, and we've got things mapped out, but to operationalize it, maybe another 6 months. Don, Rich, what do you think?
I think that can be shaped. It all rolls out of picking picking an accelerator company and then finalizing the agreements and the agreement, and like you said.
I mean, we obviously want to be sensitive to your timelines, and if there's an urgency, we just want to do it safely and get you good people too. That's key. I mean, that's one of the things we worked with Ann Rhodes about. I mean, the three main areas: a hiring methodology, a performance management methodology, and a rewards and recognition methodology. And I can tell you that the 30 MDs and PhD nuclear physicists in the department weren't real excited about going through some sort of performance evaluation process, but it does help you get better. And when it comes to hiring, the key thing is, you got to have skill sets, expert skill sets, but if you're not going to work well with the team and put patients first, we pass on people like that. So that's why the recruitment sometimes, I mean, typically we'll bring in, we'll have 10 or 15 people that apply. We'll interview them all on the phone, and bring in about 5, and narrow it down from there.
You had a timeline there. When do you quit treating a patient? I'm a cancer survivor, my wife is. I've had it for quite a while, and it keeps mounting the cost to keep me alive.
Yeah, in a lot of ways we're turning cancer into a chronic disease, like diabetes, where you can keep it under control, where it's not adversely impacting the patient's overall health and well-being, but it's variable. I mean, in prostate cancer, you can have prostate cancer that's gotten into the bones or other parts of the body and live for 10 or 20 years. Same thing with breast cancer. You see some examples with colon cancer and rectal cancer, but I mean, our goal is to do the least amount of treatment possible and keep you out of the doctor's office and keep you out of the hospital too.
But if you have a rare form like I have, Castleman, which most doctors never heard of.
Yeah, I mean, it's in the category of lymphoproliferative disorders, and some of these biologic agents, these monoclonal antibodies, now you can take for a long period of time and really control the disease like a chronic disease, and you know, these things can cost like $10,000 a month. That's really one of the issues about cost of healthcare. My father died from pancreatic cancer back in 2006, and he was on one of these biologic agents where it was $10,000 a month on top of chemo costs and radiation costs. So, you know, but obviously this is very effective treatment because you look healthy, and we like that. So.
Well, thank you, but under this health care plan, when do they come to the point to say stop?
Well, I mean, you know, one of the things I say all the time, if you're 70, you're much more likely to make it to 80 than me. If you're 80, you're much more likely to make it to 90 than me. So, you know, you don't discriminate against that. If your overall health and well-being is pretty good, you need to control the disease. And as long as it's tolerable, it's doing its job for disease control. So it can, I mean, the oldest patient I ever treated was 102. And that was not doing the wrong thing.
Any other questions? Okay, thank you. Thank you very much, Dr. Clark.